So I think most of you have met me so far. My name's Rachel. I'm part of the care team at PPMD, and I am joined by some fantastic professional colleagues who are going to talk to you about early childhood clinical care. What I love about this session is that I have no idea where it's going to take us. So this is all about the questions that you have that you haven't had a chance to ask before. So what we'll do is we'll have each of them introduce themselves, talk a little bit about who they are, where they're from, what they do, and then from there, we'll just open it up for Q&A and see where we go. So I think we'll just start right here with Eric Henriksen.
Hi, everybody. I'm Eric Henriksen. I'm at the University of California, Davis in the Neuromuscular Research Lab. And I actually do a little less in clinic, but part of what I do is I'm a peds and adult developmentalist, which is, you probably heard my shtick before, but it always sounds like I'm going to pull a rabbit out of a hat or something. But essentially, what that means is that we look at sort of psychosocial development against the background of muscle disease and against the background of family relationships and resources in the community. And it's a very multidimensional way to look at individual development and to think about how things like having a muscle disease could change your track of individual development over time. And so, so from that standpoint, so for today, I'm standing in for Natalie Truba, who wasn't able to join us, who is a clinical psychologist. So we overlap a little bit. And so that's kind of my topic area. And I'm happy to talk about young children and kind of where we, what we think about kids with dystrophinopathies as toddlers and young children and getting ready to go into the school environment and things like that. And that's frequently a topic of conversation in clinics. So I am at your service.
Awesome. Thank you so much, Eric. Am I there? There we go. Thank you, Eric. All right, next up we have a former colleague of mine and good friend, Dr. Richard Schell.
Well, welcome everyone. I am Richard Schell. It's funny, I sit next to Natalie Truba in our clinic as well, so this worked out perfectly. And we sit and we talk about ways to help these young men be more compliant with therapies all the time, especially with behavioral things. And but I'm a pulmonologist, and it hit me like in our last session about GI. I think Rachel, you asked, like, who other people in your clinic, if you don't have a GI doctor there, can be your advocate? And I find like I'm always, advocating for the GI clinic and asking those questions and finding out like who needs to see the GI doctor. But I, from a lung care standpoint, in early childhood, I feel like I'm more the advocate in the clinic. I'm going to talk about respiratory health. And I'm just more, I would consider it more anticipatory guidance. These are the things that we're going to talk about in the future. But if you see these signs happening or these symptoms that you're seeing in your child, I want you to bring those up and talk about it so that we can, we don't want to miss anything as these kids get older. But I also don't want, we talked about a lot in the last session, like I want to know from you, like when do you want to hear about all of these things that will happen in the future, but really aren't something that we have to go into great detail when your kid is 3 or 4. However, I mean, as a lung doctor, I've picked up kids with asthma, other respiratory health kind of things. We're there to help for everything that could, possibly come up from a breathing standpoint.
Awesome. Thank you so much. All right, next up, we're going to have Dr. Sue Apkon introduce herself and tell you a little bit about who she is and where she practices and what she does.
Great, thanks, Rachel. So again, I'm Sue Apkon. I'm a pediatric rehabilitation physician, and I am the co-director of our neuromuscular clinic at Children's Hospital, Colorado. So when I'm in the clinic seeing boys and young men with Duchenne, I kind of wear 2 different hats. Sometimes I'm focused on the kind of the neuromuscular issues specifically, so I'll talk about things like use of corticosteroids, clinical trials. I'll also focus on some general medical health issues, making sure the kids are not having issues with constipation, for example, or eating well. Work closely with my colleagues in nutrition, making sure they're up to date with their immunizations and so forth. And then when I wear my rehabilitation doctor hat, I'm focusing a lot on function. So there's sort of a couple of different buckets that myself and my physical therapy colleagues will focus on. So we'll focus on exercise, therapy, bracing, and equipment. And so depending on sort of the age and stage of the child, we may have different conversations about some of those issues during a clinic visit. So I'm happy to chat about any of those things, either kind of the neuromuscular hat I wear or the rehabilitation doctor hat I wear.
And the clinical trialist hat.
And clinical trials, yes. Happy to talk about clinical trials and how I
can't forget that one.
Yes, sorry, I'm happy to talk about how I think about clinical trials.
Awesome, thank you, Dr. Apkon. And then last we have Grace Gough, who may or may not have slept on a park bench last night.
I didn't sleep on a park bench, but it was close. It was close. I am a registered dietitian. I work at the University of Utah. We have a sister clinic at Primary Children's Hospital as well, and we service a lot of the Intermountain West. We see patients all the way from Idaho and Montana and Wyoming, a lot of southern Utah, Vegas kind of areas, and they all sort of converge in Salt Lake City. Nutrition is pretty pervasive. I would say that little pieces of nutrition fall into conversations about GI, conversations about respiratory, conversations with social work, conversations with PT, and we just have sort of a lot of overlap and kind of a broad, sweeping. I mean, we just kind of touch a lot of places. So I see patients and families. We see people on an individual basis. We do some group work and discuss all things eating and nutrition to help our patients, both kids and adults, make sure that we're staying on top of things from a nutrition standpoint, and not having that be a barrier to help.
Awesome, thank you so much. So obviously we've got some super smart people here. If you were in the newly diagnosed session earlier yesterday, you heard me say there are no stupid questions, there are no silly questions, there are no questions that are too small or too big. So any burning questions that you have, I want you to ask them. So we've got a mic over here on the stand. I also have a mic I can bring to you, and then our friend Brian over here is monitoring questions that come in from our virtual attendees. So who wants to go first? What questions do you have? Otherwise, I'm going to pick one of you and make you ask something. So no, we'll go you, and then we'll go here.
Okay. So we heard this morning from Dr. Truba about how the autism in kids with Duchenne can look a little bit differently. So one thought that I have is, do you have any tips about explaining that to our son is 3 and he has an autism spectrum disorder diagnosis, and he's getting ready to start a developmental preschool. They have other kids there who also have autism, but don't have his version. There are no other kids that have Duchenne. Right. Do you have any tips about explaining that to them or talking about how it might be different? Yeah,
I think so, actually. This question came up this morning as well. And one of the things that we think we understand about autism-like behaviors in people with dystrophinopathies is that what we're seeing may not be sort of classic autism, where we have children or teens or young adults who really have a hard time with this concept of theory of mind, of putting themselves in the place of another person and anticipating their emotions, their thoughts, how they're going to react to a situation, things like that. Which is one of the sort of hallmark characteristics of autism per se. It's a very inward-looking sort of constellation of different behaviors. And I think that what we find is that some of the things that are characteristics of autism, like the repetitive behavior, like the limited or very focal areas of interest, like just on maps or letters or the color spectrum or things like that. That's part of it. And then the social contact and emotional regulation part is really where we see a lot of the behaviors that are maybe a little more challenging from that standpoint. And so the good news is that there are a lot of programs for young children that really focus on the social elements of interacting with peers and figuring out how to enter a play situation, or figuring out how to recognize and acknowledge that, somebody over here fell down and cried, and you should go over and pick them up and give them a pat. These kinds of things that kids with DMD, they're actually okay with. Part of it is developing a familiarity with people. We think is it's less of a thing that you see with sort of the typical autism behaviors. And so as kids with DMD warm up to new people, they're very, lovey and huggy and, that, and so we don't want to call this not autism, right? But because to do so would make a lot of people not eligible for services. But we do suspect that it's quite different. And it maybe in the context of the school situation, getting teachers to work with students, I would kind of recommend that they find ways to reduce that social anxiety and that social tension, whether it's by having a conversation where you don't necessarily have to have eye contact, or you work to tell somebody something and then have them reflect it back to you. And because often something that I hear from teachers is, this child never pays attention. And I say, well, I bet they're paying attention. They're just not looking at you because it's hard to look at you. And so, those are the kinds of things that I think can be applied sort of universally to a lot of people with dystrophinopathies and other anxiety-related disorders that that can be helpful in the early in the preschool prep situation. So that's kind of my approach to that. So just my thoughts there.
Can I add a couple quick things
Yeah.
that I was thinking about as you're talking?
Mm-hmm.
One, use your resources and share those resources with the teachers. I think in the developmental preschools, schools in general, teachers are sometimes starving for information about a particular child or condition that child might have. And so use the resources. So on the Parent Project Muscular Dystrophy website, there's some wonderful resources around school and cognitive behavioral issues. And so print them out or send the PDF via email to the teacher, maybe something that's well received. The other thing I'm thinking about is language. And so as many of you may have either experienced or may know, that language delays is sometimes the first thing that we see in the setting of Duchenne. And you certainly see that in autism, right? Very restricted language or no language. But what's different in the setting of Duchenne is language comes along. And so if the autism teachers don't necessarily get that, their approach may be a little bit different working with your son versus a child with more traditional autism. Language we see the development of language in the setting of Duchenne. That is just part of what we see. And it looks that development of language, the trajectory in which you're experiencing it is very different than what you would see in autism. And so recognizing that difference is important.
I actually want to highlight something that you just mentioned, Dr. Apkon, and that's the resources that we have available. So if you didn't have a chance to check out our resource fair, we have Education Matters. So Education Matters is a 3-volume booklet. It's substantial, and it's broken down by age group. So there's one for your age sons, there's one for the middle childhood, and one for teens and adults. And it's a really great resource because it's written by people who have expertise in Duchenne and learning, but it's even got some pages in the back where you can basically jot down notes and trade it back and forth with your child's teacher. So it's something that you can give the school to empower them to better understand Duchenne and how the Duchenne brain works, for one, and then use that as just a tool to really keep those lines of communications open. The other thing that we launched here probably, 8-10 months ago, we have a educator's masterclass. And this is a masterclass that we have available. It's an audio-visual with it's got the video, they're Zoom boxes, let's be real, they're Zoom boxes, along with the sound. So you can either listen to it, you can watch it, whatever. And it tracks along nicely with that educator's masterclass, but it also digs a little bit deeper with some really practical advice too. So the intended audience for that masterclass are educators. So preschool teachers, IEP and 504 coordinators, school administrators, all of these different types of educators that could potentially touch your son in that academic setting, so that we're giving them all of the information that they need to understand what's the same and what's different in a kid with Duchenne, so that they can make him as successful as possible.
One final comment, sorry.
Yes.
Is that okay?
No, you may not.
Neuropsychologists and neuropsychology testing. So, some neuropsychologists, I'm not an expert in it, would say maybe 3 is a little bit too young, but certainly as kids are entering school, like kindergarten, we want to get a neuropsychological profile. That is basically a pencil and paper puzzle type of half-day, full-day testing that really helps us as providers, teachers, and most importantly, parents understand how the kid thinks, how they're processing information, how they're retaining, so memory, how they're paying attention. And it is super important then to be able to share that information with the school. What the school testing is great for what it is, but it's generally fairly restricted to the learning part of it. And neuropsych testing is much broader. They will cover some learning assessments, but also much more broadly some of the cognitive types of assessments as well. So I'd encourage that if you have not had that or talked to your provider about it, I would encourage you to talk to them about it.
And those are great ways to sort of identify areas of strengths and areas of weakness as well, because everybody's different. And actually, so the work that I was showing this morning from Amy Wagner, she was using some of the more traditional autism screening tools that are sort of parent report, and they're not diagnostic. If you score in a concerned range, then it suggests that maybe this is something that you would want to go and get a professional evaluation, a neuropsych evaluation. But what we see with those tools is that they can sort of differentiate between the kids who may have some problems with emotional outbursts and conduct versus people who have some more challenges in social and peer interaction, things like that. And those are valuable tools to have for going into that kind of setting. So even using some of those, the strengths and difficulties questionnaire, the social responsiveness scale, some of those are helpful going in ahead of time. Just understanding that they don't diagnose any disorder. They just are helpful in identifying kind of what the pattern is generally of what might be going on that would be an area to focus on.
Awesome, thank you. All right, let's move on to our next question. I think I have one right here.
The slides that from the presentation earlier, will they be available? Yes. Okay. Hi. So Dr. Apkon, is that right? Hi. So my grandson Desi's just about 4, and so he loves a scooter, like one push with one leg, ride it with the other, and he keeps up with his 6-year-old brother, and it's like his favorite thing to do. And so I'm just wanting to make sure, is that something he should not be doing, because he gets so much joy out of it, and how does that affect him?
It's a great question, and my simple answer is I don't restrict kids at all. I want kids to be out and being kids, playing and doing the activities that they as individual kids want to do, or as a family that you enjoy doing, and I do it without restriction. Are there certain activities that are probably less taxing on the muscle than others? Sure. I live in Colorado. In the winter, we ski, and I have kids with Duchenne that have skied. And skiing is probably not the best activity because it really stresses the muscles. But if that's what's important to the child and to the family, go for it. There's a couple of sort of general guidelines I use. So if the next day your grandson is complaining of a lot of pain, if he has a hard time getting up the stairs to go back up to his room or get up off the floor, or if he has Coca-Cola colored urine, and I can talk about that in a second, that's called rhabdomyolysis, a little muscle breakdown. that then gets filtered through the kidneys, and it looks like tea-colored urine. If any of those things have occurred, maybe he's pushed himself a little too far. Kids do have a hard time regulating themselves, so then maybe as an adult, you regulate a little bit. So we're gonna go out, and instead of going nonstop for an hour, we're gonna go nonstop for 10 or 15 minutes. We'll take a little break, maybe do another activity, and then we'll get back to it. So helping him regulate, but if he is not having any of those issues, and more importantly, he's enjoying it and he's successful at it, go for it.
And then one question for Dr. Schell. So pulmonary, I mean, he's little, he's, just gonna be 4. But I do notice, he snores already, like he was snoring, and so needing a CPAP here myself, is that any indicator of anything to be concerned about?
That's a great question too. From a breathing standpoint, if he's just snoring and he's sleeping through the night and he's waking up fine and doesn't have any daytime symptoms where his nap times have changed or he's sleeping more or you're noticing behavioral changes during the daytime, my guess is that there's nothing wrong with snoring. I would imagine if I asked everybody to raise their hand and who snores at night, we all probably snore at some point. The interesting thing about that question is that there are many kids who are in this age group that get put on steroids, and steroids sometimes make you gain weight. That can also increase the size of your tonsils. So there is, at least from a research standpoint, my colleagues at Cincinnati wrote a great paper that, sleep disordered breathing can happen, or obstructive sleep apnea can happen in the younger age group with Duchenne a little bit more. And some of the treatment is just like we would normally do. You'd go to the ear, nose, and throat doctor, and they would do a tonsillectomy, and hopefully that's all they need. But we do have some younger kids that do need CPAP. But I usually don't recommend a sleep study unless you're seeing some other symptom besides snoring.
Sorry. And the other question to accompany that is small dose of melatonin. Could that increase the snoring?
I don't know the exact answer to that. My guess is no. Melatonin is a relatively safe drug. I mean, our bodies make it. It is used as a sleep aid to help kind of reset the time that you go to sleep and help some kids. It's been very helpful in some of our behavioral kids too to help them, calm down during an active day and get to sleep. It doesn't work in everybody, and the one thing I say about melatonin is a lot of physicians I've seen, they'll just keep increasing the dose, and you can buy it over the counter and it says it's safe. And once you're getting to a higher dose, like over 2 milligrams, it's probably not gonna do any more to give you more. But I don't think there's anything about melatonin that would get them into a deeper sleep to cause more snoring.
Thank you.
You're welcome.
Can I, so your comment about using the scooter, one of the things that I've come across, and I've had that kind of question as well, just in the research lab side, and going back to some of the behavioral challenges that we have with kids, some of our Duchenne guys have, some sensory issues, and they want a certain pair of pants because it's got the right texture. And we see this a lot with folks wearing night splints, and they don't like the feel of it, and they kick them off at night. But another thing that I've noticed is helmets for doing bikes and stuff, and they don't necessarily like the feel. And please, please, please make that that is the sacrosanct. You must wear a helmet in order to do these things, because they're really good at convincing us that I just I don't like it. And so helmets, please.
And I think it helps too if they have siblings to make sure the siblings are wearing the helmet too, so that everybody's wearing a helmet.
Yeah. Even if it's the cool Iron Man helmet, you have to Iron Man wears a helmet, so do you. That kind of thing. Make it exciting somehow.
Hi, I have 2 questions. So one is around nutrition. So usually what we hear is that basically, these boys try and give them, a well-balanced diet as much as possible, and we do that. But has there ever been any sort of research into actually what are maybe top 3-5 foods that can help them, like maybe reduce inflammation, or like what would you recommend for diet basically? Like anything specific, anything more specific than that?
That's a great question. I get asked things like that a lot, especially about inflammation. The research is really poor as far as that goes. Generally, what we look for these kids is a really balanced diet. We want to make sure that they're getting fruits and vegetables, developing a healthy relationship with food at an early an age as possible. And it gets complicated because, as has been discussed at length, we have a lot of sensory processing disorders. We have a lot of autistic tendencies that complicate eating and make it difficult. And so it's really easy in theory for me to say, this is what your child should be getting. And it's insensitive of me to say things like that when parents take these kids home and 3 times a day or 4 times a day, it's an almighty struggle. And so, everything is absolutely within reason, and we try to tailor specifically to each kid and what they're dealing with. But generally speaking, we really we want this balanced diet for these kids. We really want to focus on fiber, making sure that they're finding ways to get fiber. So we do try to encourage fruits and vegetables early and developing those positive relationships and whole grains. And I think the biggest thing is eating consistently across the whole family. We don't want to do anything special. We don't want to be singling these kiddos out. We want to be eating as a family unit so that everybody's diet is the same. If something is off limits for one kid, it's off limits for everybody. If you're going to try to avoid having things in the house for one person, you avoid having it in the house for everybody. And that's really what we want to focus on, just starting at as young of an age as we possibly can and developing those really healthy eating habits, especially because once we start these kids on steroids, we really start to fight weight battles and other kind of battles regarding food. There's a lot of fighting with food. I think there's a lot of coping with food, especially as these kids age and they're dealing with some of these issues and these anxieties and things like that. It becomes a really complicated emotional issue as well. So if we can establish really healthy eating practices early on, that's what we want to shoot for. I really wish that I could tell you that there was a fantastic food, like everybody go eat kale, which I think tastes like mowing your lawn. But it just doesn't show that it does anything special, anything better than any of our others. It's just a really great food that does something different than blueberries, but it's not gonna do anything fantastic. So we want to make sure that they're getting adequate amount of protein, but we don't need to overdo it on the protein. It's not going to help anything. It's not going to prevent disease progression. We want to make sure that we're isocaloric as much as we possibly can, getting just the right amount of calories, not more, and definitely not less. But from an inflammation standpoint, I don't think that taking fish oil, for example, in these kids is going to do anything. So be wary of things like that you may look at or you may read on the internet. We really want to stay away from anything that sounds either too good to be true or something that's going to be very unpleasant for your child. I never encourage anything that's going to cause strain on relationships between parents and their kids because of some thought or idea around food. Does that answer your question sufficiently?
Yes, it does. Yeah. Thank you.
Okay.
I just have one more. So this one is around behavior. Fortunately, my son, we and our clinicians don't think that he's affected from an autism standpoint, but we do see, certain peculiar behaviors, like, for example, like being very particular about things, and like if we say we're going to go at 6 o'clock, we're going to go there, and something happens, and then we can't leave at 6, then a resistance to change, like being very perfectionist, some traces of anxiety. I mean, some of that might be coming from me, but so, and on top of that, these kids are on steroids, so sometimes I struggle with sort of and like, for example, like in school and in public setting, my son is very well behaved, he like very, very well behaved. but at home it's, like he won't let anyone else talk. Like he just wants to talk and talk and talk and talk. So sometimes it's just, and like when he's, like there could be bursts of crying that go on for like 45 minutes for no reason at all. So like as a parent, I think it becomes difficult to sort of should we discipline them, or should we attribute it to some of it coming from disease or steroids? Like how do we sort of like try and make some sense out of it?
So I'm not as much of an expert in the clinical intervention with these kinds of behaviors, but that's something that a lot of my neuropsych and clinical psychology colleagues have some experience with. And I will say that the behavioral rigidity is one of the things that we see very commonly that has overlap with a lot of the autism spectrum-like behaviors. And so this is a kind of behavior that's seen across multiple different childhood developmental disorders. And part of that behavioral rigidity is they've set up a certain expectation and they're used to a routine, and as soon as you get outside of that track, their threshold for emotional outbursts is lower. And so you can almost, it's hard to anticipate because life is a little less predictable than we would like it to be, when those kinds of things are going to happen. But establishing a set routine within the family and daily routines and things like that is helpful to an extent, but also finding ways to work with kids so that they can understand that even if things don't go exactly the way that they planned, they might just be different and not worse. And so, I think that's a great, you shouldn't be at all self-conscious about talking to your behavioral healthcare folks about exactly that kind of behavior. And, from a discipline standpoint, it's kind of like what Natalie was talking about earlier. I don't know if you had a chance to see that session, but, the idea of understanding that there's that threshold above which their kids are likely to kind of have a meltdown, and thinking about, as a parent, anticipating those situations so that you can try to catch them before the meltdown happens and before they hit that threshold to kind of address them ahead of time is one way that she recommends kind of working with folks who have those sort of challenges. So it's worth a detailed conversation, and potentially some ways to say what can we as parents do to learn to help to modify the situation. So.
The other comment I would make is that yes, steroids can modify a child's behavior. If the child had no behavioral issues before they started steroids, they start steroids and their behavior is now up here, then yes, the steroids probably have played a role. You can make changes to the steroids, whether it's changing the doses around, going to weekend dosing versus daily dosing, going from one type of corticosteroid like prednisone to deflazacort, or potentially vice versa, may have some impact. The other thing I'll say, you asked the question, or you made a comment, weren't sure if you should be frustrated about it or blaming the kid versus the steroids. What I would say is, remember that there's dystrophin in the brain normally. If you have Duchenne, then the dystrophin in the brain has changed, and that is the underpinning of the cognitive behavioral manifestations that we see. You have that on top of the steroids, plus or minus, causing some issues. I'm not a parent, but what I would say is I would blame the condition, I would blame the steroids, and maybe less so the kid for being a challenging kid. It's a challenging situation that he has found himself in. It's a challenging situation that you have all found yourself in. And if it helps an individual person to sort of take a step back and say it's the condition that's leading to all of this, then you have lots of reasons to say the condition is causing some of these behavioral changes.
The brain thing that you talked about, do you think the brain thing that you talked about, like how you need dystrophin in the brain, Does that apply to all the mutations? Because my understanding was that only basically the isoform that goes into the brain is basically towards the higher exon ranges and not like towards the earlier exons. But do you see that even with earlier exons, the dystrophin in brain is any different than?
Yeah, so that was the prevailing theory, I think, for a while, was that we have brain-specific isoforms of dystrophin.
Yeah.
And so for the folks who have mutations in that region that would affect that shorter version of dystrophin, that's where we would see the cognitive challenges. But what we're finding is that it's sort of a two-dimensional, it's a multidimensional challenge here. So we know that for individuals who have those mutations to the DP71, DP40 that are more brain specific, that's part of the population that tends to exhibit some of the more profound developmental delay, lower on average, lower average intelligence by IQ. It's a very blunt object, the whole IQ idea. But that overall, we see many of these behavioral challenges even in guys who have what we would assume to be the typical brain isoform dystrophin. So they have mutations before the middle part of the dystrophin gene, and so we're really looking much more at the expression of full-length dystrophin in the brain now, and full-length dystrophin actually helps to anchor some of the neurotransmitter pores at the synapse. And so we've seen some evidence in animal models that missing the full-length dystrophin actually reduces some of the density of these neurotransmitter pores. So even though the neurotransmitters are being produced in the right amounts, the amount that's actually getting into the next door neighbor cell to transmit that signal down is reduced. So we suspect that there's a role for both the brain-specific and the full-length dystrophin, but that many of the things that we see are probably due to the full-length.
So just a question on tips and tricks for getting picky eaters to try new stuff. With those autistic type of behaviors in there, my son is what we call on his red diet. If it has ketchup in it, if it has strawberry jam, or if it's tomatoes. Any tips, tricks, how to get other fruits, vegetables in there? And
I have lots of ideas.
Oh, go for it.
Well, so as a pulmonologist, I take care of a lot of patients with cystic fibrosis. And it's actually now more of a digestive process. And we spent a lot of time talking about getting them to gain weight and to eat. One of the biggest tricks, I don't know if you like to cook, but if they can see you cook and you get them involved in actually making the food, I found more kids with that positive reinforcement. Like instead of buying Smuckers, which, I should you should buy Smuckers, it's an Ohio product, like it brings money back into our state, but if you have strawberries and you make your own jam, maybe then the next time you get blueberries, you can probably make jam from kale too, but it probably would taste the same.
No, yeah, you might be able to.
Just involving them in that process seems to help. And I just wanted to reiterate what you said, like getting a healthy attitude and a healthy diet early on. Obviously I failed in that a long time ago because if there's a piece of cake in front of me with icing, like I cannot say no to that. Whereas I can say no to other things, but I think that it's all in moderation. You should have that. And what I see in clinic a lot of times is it's a stressful day. They're hungry. You run out of snacks. It's so easy to run to McDonald's or Cane's and get them the sweet tea that they want that has 5,000 calories in it. I mean, getting them early on to understand like water is the best thing and milk is the best thing, and there's lots of waters that have flavors in it that you don't even have to worry about the sugar, but getting them involved in those choices I think is hard, especially if they have any behavioral issues, but I think it makes a huge impact to them. And I found that at least in the CF world, like the kids that were helping to make their dinner were much more apt to eat something different than they wouldn't otherwise. I mean, I have a daughter who doesn't have any medical problems, but she also puts ketchup on everything. And my daughters joke about it because she put ketchup on tangerines once, and she thought it was good. So it's kind of been a running joke in our house. But I mean, she's a high school student now, so she's not doing that anymore. But she still goes through a lot of ketchup and a lot of barbecue sauce.
I love that approach, actually. And from a standpoint of, we were talking this morning in one of the other sessions about sort of things that you can do in childhood to help foster development of autonomy and, as guys get older and approach adulthood, and being able to, find ways to get your own, cook for yourself, or, make your own nutritional choices is a huge part of the adult world. And so, really kind of creating a habit of being in the kitchen and knowing where your food comes from and knowing what's in it. I think that's fantastic. So I
think there's a lot of things too about, like, you can hide vegetables in a lot of things. Cauliflower especially right now.
I fundamentally disagree with that.
Yeah, no, that's what I was gonna say, like, you shouldn't hide it. Like,
Right.
You should get them to understand why it's good to eat this.
Yeah, I have a couple of thoughts on this too. I completely wholeheartedly agree with this of getting your kids involved. A couple of other things, and parents hate when I say this, but modeling is a huge part of it. So as parents, if you're trying to get your kids to drink water, but all they see you drink is Diet Coke, they are not gonna drink water. So, and I have very few hard and fast rules as a dietitian in my practice, but sugar-sweetened beverages for children is just one of them. There is no need for that. Kids say that they hate water because they don't remember drinking anything but things that are sweet. And so, starting from a really young age of not having that stuff in the house is really important. And that also has to be parent buy-in, that the parents are also not always seen drinking whatever, okay? And that can be anything. And I try to encourage parents to set up a yes house so that if the kid is hungry, that the snacks that are available to them are all yeses. So that you are not constantly saying, no, 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 you can't have those things, but here's one drawer in the fridge that's got yes things in it. But that they can open up the pantry and you have a box labeled snacks and they can choose any of the snacks that are in there and that it would be a great choice. So that they are sort of surrounded in this positive food environment so that they're hearing a lot of yes. Look at all of my options. I have a choice. Those types of things are also really important. And then make them as delicious as possible with whatever that means. If your kid loves ketchup and you want to smother your broccoli in ketchup, go for it. I actually don't care if, especially with things like broccoli. I grew up dipping broccoli in mayonnaise. It's just the way we did it at my house.
French fries are better in mayonnaise, though.
Lots of things are better in mayonnaise, but broccoli is good too. But that was just what we did. And when I was a kid, I would dip my broccoli in mayonnaise and suck the mayonnaise off and put my broccoli back on my plate. And I did that till I was 6. And then when I turned 6, I started to just take nibbles of only the leaf part on it, but I would never eat a stalk, forget it. But I was still dipping it in the mayonnaise, and then by the time I became a teenager, I didn't need mayonnaise for broccoli anymore. And that kind of goes away. And as a kid's brain develops, as their palate becomes less sensitive, and as they've had many exposures to food, some of these picky tendencies will go away. I'll tell you what it takes. It takes patience and it takes consistency. So there's all these numbers that people throw out about number of exposures that a kid's gonna need before they accept something new. And you guys probably know more about that than I do, but I say you double the exposures. So if it takes 42 exposures before a kid is going to accept a new food, especially with my Duchenne kids, that means they have to be served broccoli every week for nearly a year. And they're gonna reject it every time until maybe 10 months down the road of this consistent exposure, modeling, and involvement in their food preparation. And then maybe they'll start to accept it more. And it can begin with just leaving it on their plate. So we do a lot of food therapy with some of these kids of just helping them keep unaccepted foods on their plate. They don't have to touch it, they don't have to eat it, but what they see is that what's on their plate is exactly the same as their sister's plate, and it looks exactly the same as their parents' plates, and that they see everybody else eating it, and even if they're not going to, they don't have to eat it, but it has to stay on their plate. And that's like step one. And then you just consistently expose them. You keep the language really positive. We really discourage, you have to have a bite of this before you can have any of that, okay? If you're gonna plan on having dessert, I recommend serving it at the same time as dinner, because then we're not elevating dessert as this reward that they get for eating something or doing something, and it becomes this, elevated food on a pedestal that donuts are here and everything else is here. But if it all comes out on the same plate at the same time, everything becomes equal and they can eat that whenever they want. So there's things like that that can be done that can also sort of help just break down some of these barriers that we see in these young kids with their eating. And it does get better as they age. Yeah. That I can guarantee. But if they're coddled consistently when they're little, they will never work to become more adventurous eaters later. So being consistent and trying as hard as you can not to give in at a young age is really important. Kids generally aren't advanced enough cognitively to starve themselves. If they're hungry, eventually they're gonna eat. They just can't. For the same reason that you cannot get a kid to take another bite of food or finish when they are done, they are done. And that is something that is biologically in kids that eventually we beat out of everybody by the time they're a teenager, and we lose all sense of how much we should eat and when we should be stopping and at what point we've had enough. And that's a separate conversation, but we need to teach kids to listen to their bodies, to listen to hunger fullness cues as much as we can. Now, we really screw with those when we put these kids on steroids. Things get really funky with how kids feel hunger and fullness. And that's a complicated issue that we work really carefully with these kids and with their families of really learning the difference between biological hunger and all the other types of hunger. And we have to get a little bit more structured about times of the day when we can eat. And sometimes if you have a picky eater that thinks, I know that if I don't touch any of this food, this yucky food at lunch that I really don't want to eat, that in an hour, when I ask my mom for fruit snacks and all the snacks, that she's gonna say yes. So I am not gonna eat lunch because I know that in 45 minutes, I can have whatever I want. And so by setting up food, times when your kitchen is open and times when your kitchen is closed can really help with some of that behavior. And then the discussion at mealtimes becomes, make sure you fill your tummy because we are not eating again until the kitchen opens again at 3:30. And there will be no food eaten by anyone in the family. Again, we're talking about a lot of parent and family buy-in until 3:30 when it's snack time. And the kitchen will open for 30 minutes. And you have your snacks and everything is a yes food. And you can say yes to the cheese stick and the apple slices and a little container of peanut butter or some popcorn or whatever they want to eat. Those are all yes foods, and they get that 30 minutes while the kitchen is open, and then the kitchen closes at 4. and it is closed again until dinner, and they're gonna come to you starving at 5:15. Absolutely, I'm gonna die, I'm so hungry. And the conversation then goes to, I'm so glad that I can already tell you're gonna eat a great dinner because your body is already telling you that it is ready for food. That is fantastic. Come and help me cook. Come help me make dinner tonight. Let me show you what we're gonna have. You can help me make it. Come help me set the table, and involve them in the whole process. And then when the kitchen is open again at 6 for dinner, and they can eat, and then the kitchen closes at 7. And there's no reason for anybody to be eating after 7 o'clock. We know that eating late messes with sleep and circadian rhythms, and we know that eating late affects digestion and the way we process and utilize those nutrients when we're sleeping as opposed to when we're up and about. There's so many different things. So by building this structure and these positive conversations, by involving kids in the eating, by exposing them to foods really early and trying really hard not to cater to them all the time, because I'm a parent, I have 4 small children, I get it, that you can get a little bit more successful. But it does take work, it is really frustrating, and you throw away a lot of food. And I'm sorry.
I just learned what I was wrong. My parents put donuts on the pedestal. That's why I can't say no to cake.
You think the donuts are, right? It doesn't matter. This is something that we just sort of developed, that this is a better food. But when it comes out with our meal, you can eat your donut first. That's fine. All you get is that one portion of it, right? If it's a cookie, you get one cookie with the rest of your dinner. That's when you want to eat, that's totally up to you. It isn't any better than anything else, but we're not filling up on cookies.
I also think that other countries have a little bit better, like we're so set in our minds, like breakfast has to be a bowl of cereal and a glass of milk or orange juice. Like I remember traveling and going to breakfast, and if you're in Europe, you get a piece of meat and a piece of cheese and maybe a piece of bread that you put some really good butter on and a really good cup of coffee. But like it doesn't have to be like Frosted Flakes and a glass of orange juice. If they want to eat cheese cubes and a piece of salami, and that healthy-wise, I think, or if they want asparagus for breakfast and you have it available, if the kitchen's open for that.
Yeah. Sure. One thing that we're looking at in our clinic in particular is whether or not we can start utilizing a diabetic diet approach, which is basically carb-controlled, really consistent carbohydrate intake across the meals to help mitigate some of the weight gain that we see and some of the blood sugar dysregulation that we start to see in these younger kids. But I do think that making choices of, is my kid getting a little bit of protein at breakfast? Because I know that they're gonna be feeling full longer if we have given them a mixed meal as opposed to giving them like a bowl of Frosted Flakes with skim milk, which is fine. I mean, I love Frosted Flakes, but chances are good that your kid's gonna come in hungry at 10, as opposed to if they'd had something with a little bit more of, a different kind of nutrient structure with some fats and some protein in there. Like at our house, we love our sugar cereals, but they're a weekend thing only because I know that when my kids have Lucky Charms for breakfast, they are hungry at 10. And I don't want them hungry like that at school. And so, we try to do different things on school days. And so, there's things like that you can do so that they do get the fun things that they like. I'm not saying there is a place for sugar cereals. But can you find a way to structure it so that those are just on the weekends so that you can help them when they are hungry again? And what you say then, when they come in hungry at 10 is, we've got 15 minutes for a small snack. Here are your good, morning snack options. It's a hard-cooked egg. Maybe it's some salami or some turkey or, whatever they find palatable in the morning at that time that's going to help give them that little boost that they need to make it to noon when the kitchen opens again.
Yeah. I really like what you said about the family participation in meal prep too, because one of the things Lucky Charms are one of my favorite things ever.
They're delicious.
And, I mean, they light up that reward center, right?
Totally.
Like, oh, this is awesome, I'm gonna get Lucky Charms. I have that response. I'm a 51-year-old man. My wife gets Lucky Charms at home. I'm like, I'm gonna eat those right now. But but the idea about lighten up that reward center around mealtime can also be social reward. It can be warm fuzzies from mom and dad. It can be this is family time that I really enjoy. So there are lots of other rewards that encourage us to develop healthy attitudes with food that we can get that are not specifically because of like, high sugar, high carb. And so I think that, and the other thing that you got me thinking about is, that Natalie was talking earlier in her talk today about sort of the 2-year-old, that we sort of think about a lot of our guys with DMD as being somewhat young for their age. Like, if they're 7, 8 years old, maybe if they're behaving like a 5, 6-year-old, that's kind of what we would typically expect in this population. And when we think about how babies develop a taste for novel foods or taste for new foods as we introduce them into the diet, there are very few things that you give a baby right off the bat that they're like, the texture is weird or something. And we have a lot of kids who it's hard for them to get used to new textures and things like that. So the idea of it just taking longer to introduce these new kinds of foods, whether it's a taste or a texture or something, when you combine that with the behavioral rigidity of I like strawberry jam, it creates a challenging situation, but it does just it requires patience. And the long game of it's not going to be critical for them to be eating broccoli, next week. You want them to be eating broccoli when they're 15 or 20 or 25. And so, you'll get there eventually. But in the process, make it fun.
Yeah, and don't put a huge pile of broccoli on their plate. Put one piece of broccoli on their plate, and you can tell them, you don't have to eat it. I'm not asking you to like it. And at a certain age, you can say, you don't have to like this. You don't have to eat the whole thing, but you need to try it. I know you didn't like it last time, but how do you know you're not going to like it this time? And so there are conversations you can have like that throughout the process as well. And I do think that there's no better time to start than when they're little. But do start with those small portions. And then the other thing that we see a lot is just a lot of coping with food. Whether that's trying to placate some kind of a breakdown that a kid is having, or if they're just totally flying off the rails, and here, let me give you something, a treat or something to calm kids down. This becomes a really heavily ingrained coping mechanism that just is not healthy. And so really trying to find other ways to help kids cope with emotions besides feeding them things. Especially as those things tend to be sweet things. Moms carry suckers in their purses all the time so that when their kid's having a meltdown in the grocery store line because they don't get to have the king size Twix that they want, here, I brought you a sucker. What is that teaching? What are we teaching in those moments? And so really working hard to utilize food for what its purpose is. And yes, there's a place for emotional eating, there is a place for social eating and all these different things, but that we're not constantly gravitating toward food to help kids cope or help parents cope in various situations.
Yeah. Hi, so I have a question about fluid intake. So my son was recently hospitalized because of an abdominal obstruction. He's 3. He has a little GI stuff, so he's got a lot of lactulose daily. We try to get him to drink water. But what I understood is that a child can survive quite a little bit of time with eating a little bit, but water, not so much. Like they need water, they need to have it daily, and they need a lot of it. And in some cases, our son just doesn't want to drink water, and it's like it doesn't matter if it's juice, milk, he'll eat. He just won't drink water. So, and I know that, and it's important that he does drink the liquid, especially because he's prone to constipation, and we got a lot of trouble recently because of that. So, do you have any advice on how you push water when he has that same stubbornness? That's not really, we really need to have him drink it.
Does he drink anything?
He does. You give him some water, he'll take a few sips. No thanks, give me some pasta. Give me we try to give him fruit cups. We try to give him, foods that are very high in water. Yeah. But that doesn't seem to be enough. We're just told, no, he's got to drink more. And he does drink it, but he's very stubborn about it. You know, he's got, you know, the ASD thing, he's 3. He's just stubborn, and we're very constantly trying to like come up with strategies to push water on him, and you know, like, why don't you try some water? You take a bite, have some more water, and he does drink it. But as I said, like recently, he just kind of something went wrong. He just didn't drink enough water, or maybe he drank too much. He ate too many like dry foods that caused the hospitalization. But it's something that we just struggle with all the time, and we're just not really sure if you have any advice on how to push water or convince them to drink more.
I just have a question, and you may agree. Is he peeing normally?
He is, yes.
Yeah. Oh.
Yeah, so and he's just not a big fluid drinker.
I mean, I would say that if he's peeing normally, like our kidneys are pretty smart. If you don't get enough fluid, you don't pee. I also understand, like, if you're constipated, yes, fluid does help, but I don't know. It sounds like it might be also, there could be a behavioral component, but, you know, it doesn't, I don't know if, it doesn't sound to me like if someone's told you, like, oh my God, the reason you're in the hospital is because he didn't drink enough water, but if he's peeing, then his body is theoretically getting enough water.
Well, that was a few weeks ago.
Right.
He got to the point where he stopped eating and then stopped drinking, and it was like, and it got worse until to the point where he stopped eating and drinking for like a day or so, and then we ended up in the hospital. But you know, but it's just that before then it was just always a struggle to get him to drink enough water, and we were giving him lactulose, which like Miralax works when you drink water.
Right.
So if he's not drinking enough water, we can give him more lactulose. It's not really going to help. So we just have to come up with strategies to get him to drink more water.
Does he ever cough? I mean, I wonder if fluids are uncomfortable for him in some way. If he doesn't like drinking like thin liquids, for example, if there's something, you know, that could be something. Otherwise, have you tried every cool water bottle under the sun? Sometimes they like drinking out of a straw better than they like, you know, they like a character water. Have you just spent a fortune probably on every water bottle that you've ever found ever? Sometimes that can make a difference, and sometimes water temperature can make a difference. Have you varied the temperature of the water across the boards to see if there's something?
We have noticed, yeah.
Yeah. Yeah, sometimes kids are sensitive about that, and so I would absolutely maybe try keeping ice water all the time around for him if that works. Some kids like it slightly warmer, they only like it tepid. It kind of depends, and parents are like, I give them water all the time, but the water out of their fridge is freezing cold. So sometimes it can be a temperature thing, the way it feels. Some kids have more sensitive mouths than others with temperature, so that could also be something. If a kid loves popsicles, for example, then I would do cold water all the time. You can also do popsicles. I don't know if that would, but they are a pretty good source of some fluid as well. Again, we don't encourage constant popsicle eating, but there are things, especially in the summertime when it's hotter and we lose a little bit more fluid, that we can be focused on. But I would try those things, and then I would just encourage him to take small sips all throughout the day. I mean, maybe he would like to have like a teeny tiny teacup from a tea set where he only has to drink, this much. And cumulatively over the day, if he does that 5 times, is way more than he would drink if you were to give him like a full bottle and say, by the end of the day, you have to drink this whole bottle, which for a kid that sounds like doesn't like drinking things is gonna be way overwhelming. And he will have way less success than that, doing a big bottle than if you were to give him a bunch of tiny little things that look really doable to him. We find the same thing with food when we're trying to get kids to eat. We are way more successful when we give them small portions and that's something that looks like they can finish the whole thing, as opposed to giving them a huge portion and saying, just do as much of this as you can. Stop when you're done. That they'd eat way less of that than they would if they were just given a small portion that looks doable. So maybe also trying really small portions of water all throughout the day and see if that can help as well.
Thank you.
So you said on the side road?
Yes.
So, and down the road, on that road. Do you think anything is
Yeah, you can set a time. I mean, you kind of start to develop really weird, like they get these barriers, you know, they get a dissociation with food or water, whatever it may be, when you start to set up really rigid things. But you can set timers on clocks or things just like you would to help them go to the bathroom on time or whatever to drink. And be like, oh, it's 2 o'clock or whatever, it's time to have a little drink, and give them 2 sips even, or 3 sips, and just see if you can build it really slowly, and that maybe over time that will increase enough. But from a hydration standpoint, like unless his pee is brown, he's probably hydrated.
Yeah.
You know, we ideally are going for that straw color, but kids don't need nearly as much as, you know, an adult. And I think it can feel really scary when we think about how much kids are drinking or how little they drink, but they're still okay. Obviously, we need to make sure that there's enough to avoid bowel obstruction, but I don't think that we can attribute that only to the lack of hydration.
You said that you're giving lactulose, not Miralax. Lactulose. Right. I mean, the thing, it just hit me, like, I have had some kids who, because you have to put Miralax in water to dissolve it, and it changes the texture, and I'd imagine, I mean, I know some kids that don't have texture issues don't like the feeling of a glass of juice or water that has the Miralax in it, even though it doesn't really taste different.
Yeah, you wouldn't take the Miralax.
Yeah.
The same thing, I could get anything I tried to mix it in, you would take the lactose, we figured out.
It sounds to me like you need to work on like cold, like maybe it is just cold.
Mm-hmm. Yeah.
So we've been hearing a lot about dystrophin in the brain and behavioral. One of the topics I like people to consider is learning style in Duchenne. There was a lot of work done a number of years ago by Veronica Hinton out of Columbia regarding the population generally in which the kids have a very different learning style, processing strings of information, following instructions. And especially with the younger kids, I think if there are interventions at school, whether that's through an IEP or some other structured educational plan, most of them, it's not progressive. It actually, these interventions can help with improving their ability to learn. And many of these kids are really quite bright. It's just understanding they have a different learning style. I hope you speak to this. My son is older. He's a college graduate, and he actually started out needing special education, both for speech and language, but also for some of his learning style issues.
Yeah, that's a great comment. And, you know, I think that, you know, when we think about how much information you can retain when somebody is talking to you, we call that the phonological loop, right? So, you know, if you think about those number string tests where they ask you to, you know, I'm going to repeat a set of numbers, and I start with 3 numbers and 4 numbers and 5 numbers, and we get up to like 10, 11, and some people can remember like, you know, a string of 15, and I always stop at like 6 or 7 because I'm not very good at that. But one of the things that we know about many guys with DMD is that their ability to process and remember stuff is often pretty good if the length of the message is short enough, right? And so one of the things that, you know, when I occasionally talk to teachers about these kinds of things is to limit the multi-step instructions, for instance. Like, you will get perfect comprehension, and, you know, these guys will do great if you avoid saying things like, you know, go to your cubby and get out your math book and come back and sit down and turn to page 5. And, you know, some kids will do fine with that. You get, you know, somebody with DMD who might be a little heightened on the, you know, anxiety level scale. One of the things that anxiety in that sort of early lower level fight or flight kind of thing does is it limits our phonological loop a little bit. Makes it harder for us to process those multi-step kind of instructions. And so one of the things I often recommend to teachers, and I think this is in that sort of DMD guide for teachers that PPMD publishes, that Joost Hendrickson and his colleagues wrote as well, is, just let's think about the length of the message that you're providing. Let's think about not simplifying the concepts, but simplifying the presentation and chunking it into smaller bits, for instance. And so I think that there are ways to explore with different kids how much they're able to process, to kind of dial in the amount of those kind of multi-step processes and instructions that that they're able to handle. And I think then the other thing that I use as a cue and a tool for teachers is to say, okay, one of the things you can also use is reflection, right? So go to your cubby and get your math book and then come back and sit at your desk. What was it I just asked you to do again? I'm sorry, I forgot. And when they go, oh, well, I'm supposed to go to my cubby and get my math book, and then you get a kind of an idea of how much they're retaining. And so instead of saying, look at me and you weren't listening, you can say, oh, okay, well, let's find ways to, I'll adjust my approach to this child and how I'm, going to have those interactions. And so, teachers need to understand that. Teachers, coaches, whomever, grandparents. And the more people kind of around your child who can understand those kinds of, minor adaptations to kind of daily interaction, the more we set them up to be successful at learning and having a positive learning experience instead of something where, somebody's just hollering at them for not listening.
And I think that's where that neuropsych testing comes into play, right?
Yes,
so you just gave a good example. Go to the cubby, take your book out, and I don't know, I can't remember the third, right? And I can't remember the third because I wasn't paying attention. So when someone gives instructions, one, did they hear? So are your ears working, right? Did you hear the request? What about your comprehension? Did you understand it? The language that was used, did you actually understand it? Was it your attention? I couldn't pay attention because I was distracted by other things that were going on around me. And processing, and we've all used the term processing speed a little bit. I want to make sure that people understand that. Processing is really the speed at which you take information in, manipulate that information, understand it, and manipulate, know what you're supposed to do with it, and then do it. Processing speed can be slow. Mm-hmm. So when you give multiple instructions at the same time, it can be really challenging. So the neuropsych testing will help sort that out. Is it an attentional issue? Is it a comprehension issue? Is it a processing issue? And by understanding which factors are involved, it then helps to come up with a treatment plan. And that's really where the gift of the teacher comes in, because they're able to then chunk it, so give one instruction at a time, make sure the room is clear of distractions, although that's kind of challenging, so that that child who has a difficult time paying attention can follow through. Is it a memory issue? There's strategies around that. So I'm a big supporter of neuropsych testing just for that reason, to understand each of those different aspects of following that particular instruction.
Strengths and weaknesses.
I have a few questions, two questions. They're kind of unrelated, but they're probably more for Dr. Apkon. One involving steroids. So I have two sons with Duchenne, and one of them is on steroids. He's 7, and he's in a clinical trial. And I also have a 4-year-old that is not on steroids. And I know there's a difference in opinion between doctors about when to start steroids. And I know some have like 3-year-olds on steroids. Well, my son's not. And I don't know what that's based on, really. I do know my 4-year-old is doing really well, and you can't really tell that he has Duchenne. I mean, he runs and jumps, and he's really active. And then also, part of that, I know hopefully there will be more clinical trials opening up next year, and he's not on steroids. And he would really be a good candidate for them, because he doesn't have any cognitive issues. He's just, it's mostly physical stuff. And I'm just wondering, I guess if I should we should be starting him on steroids? And also the fact that hopefully vamorolone will be coming out next year. Do we start him on prednisone or Emflaza, or do we wait for vamorolone? It's just, I feel like there's a lot of factors right now to consider, and it's a little bit overwhelming.
There are a lot of factors to consider, and it's overwhelming, I know, for you as a parent. It's also, I will be honest, it's overwhelming as a provider. It feels like a big responsibility to help make the right decision or help make the right recommendation for a family. Ultimately, you get to decide, right? So I'll take the clinical trials piece first. If you are a family who is really invested in participating in a clinical trial, the vast majority of clinical trials require a boy to be on a stable dose of steroids. Some trials, it's a stable dose of prednisone. Some trials, it's a stable dose of either deflazacort or prednisone. Some stable dose has to be for daily, others a stable dose of whatever regime. And every trial is a little bit different. So our team sort of takes the responsibility of understanding what trials are out there and what might be out there, trying to sort out with the family what trial you might be interested in, what trial the child might qualify for, and helping to make recommendations based on all of that. So if you are invested in a clinical trial, very likely you're going to want your child on a corticosteroid. And usually we say a stable dose for 12 weeks, but there's trials that have been longer than that. So really talking with your providers about your interest in a clinical trial, if you have a very strong feeling about what type of clinical trial, because that will help to decide when to start steroids. We definitely I start steroids for children, not that I think that they necessarily need it from a muscle strength standpoint, but that family is invested in a clinical trial, and I got to get that kid on that steroid. Typically, the daily dose is the one that is most standard, although there are other trials that, it doesn't matter whether you're daily or weekly, 2-day high dose. So that's sort of an answer to that question. In terms of when to start, you're right. I think we all have different thoughts about that. The current care guidelines talk about starting it at the plateau phase. Well, I don't know when the plateau phase is, right? I see kids in our clinic every 6 months. Now, we know that kids actually will gain skills generally until about 6, but I don't know where they're going to sort of plateau and when they're going to fall off that plateau. And so I've always been a little uncomfortable with that recommendation. A number of us are part of those care guidelines, but it is a little bit challenging. So I think at the very least following with a care team, having every 6-month standard testing. So in your clinics, I'm guessing, that you're doing a 10-meter walk, getting up off the ground, climbing the 4 stairs, the North Star. That's just part of the clinical trials, part of clinical care. And so that helps me to understand where that child might be. So I am asking the physical therapist before I have the conversation with the parents about steroids, and much of it was based on what those results showed. There is one published study, and Connolly now at Nationwide Children's Hospital published a study looking at the use of little boys, very little boys, and they did well. And their performance on the Bailey, which is a developmental test in very young children, showed that there was a difference between their Bailey scores and those who were not on steroids. That's exciting work. Having said that, at least in our clinic, we don't start boys who are 18 months old or 2 years old on steroids. I think we all have a very healthy respect for the side effects of corticosteroids. All the manifestations. In the older boys, the delayed puberty, the short stature, the weight gain, the behavioral changes. I mean, this is impact on bone health. We don't take it lightly. It's a personal decision. I do, though, if a family does not want their child on steroids, regardless of when they want to start it, I want to make sure that family really understands the benefits of corticosteroids and are very thoughtful. And I believe that families are very thoughtful about the decisions they make with their kids, but they're very thoughtful about why they don't want the steroids. Steroids prolong ambulation. There's no doubt. it prolongs ambulation. There's nice literature that out of your group, Eric, that the preservation of upper limb function, of the kids on steroids who have straight spines. I mean, we really do see benefit from corticosteroids. When to start it, again, it should be at or before the plateau phase. There's evidence that in the very little boys, there's some benefit in terms of the different dosing regimes. I think the most recent publication, the 10 days on, 10 days off, was not as beneficial as daily. There's really not a lot of great studies comparing the daily to the other dose regimes. Weekend dosing, actually, the 2 days on a weekend seem to be very beneficial. Side effect profiles, may or may not be significantly different.
That sounds similar to, I mean, what my doctors have said. I just, the clinical trial and gene therapy is something we're considering. And I know, the earlier you can do that, likely that'll be better in the long run. So I didn't know if we should start him now, or because my son's not at the plateau phase yet. He's still progressing, still growing. So my second question has to do with AFOs. My oldest has AFOs. In the beginning, he was really, really good about wearing them, and now he does not want to wear them. And I mean, his feet are really, really sweaty in the morning, and it's very uncomfortable for him. And I didn't know if there was any other type of AFO that breathed better, or if there was some way to do that. I don't know if that's a question you can answer, but I want him to wear them, so.
Yeah. AFOs, for those of you who may not be familiar with that acronym, ankle-foot orthoses, those are plastic braces. We oftentimes, we do recommend, the care guidelines recommend use at a young age, the sort of before a child starts to have some limitations in their ankle range of motion. A couple thoughts. One, if it interferes with sleep, and I'm looking at you, Richard, if it interferes with sleep, they should not be used, and nothing should interfere with sleep. So then we try and figure out, are there other ways that we can get the same benefit? So oftentimes we'll recommend using them after school when the kid's chilling on the couch, doing homework, reading on their tablet, whatever it is, for a couple of hours. That provides a nice stretch. If you've not tried sort of thinner wicking type of socks, so I've had kids, and I just don't think it sounds comfortable, but I have kids that prefer to wear their AFOs with no socks. And that may be a sensory thing. They're going to sweat. It's plastic on skin. They will sweat. And so if you can find some sort of thin wicking type of sock, the orthotists, the people who make the braces, can get you usually some orthotic socks. They tend to work a little bit better, but usually socks make them a little bit more tolerable. Also from a skin standpoint, you don't see some of the skin issues that are involved. Now, I will also say, we have some kids that just don't seem to need orthotics. Some kids who are able to maintain range of motion without them. So when a family comes to me and the parents are incredibly apologetic and they're embarrassed and they, because I always ask the question, I say to the kid, how often are you wearing your braces? And they say, oh, sometimes, and I try to quantify it, like, when was the last time you wore your braces? 3 weeks ago. So then I actually do a good physical exam, right? So if the range of motion is being well maintained and the kid is only wearing them once in a while, that once in a while is probably not really helping. And so I oftentimes will just discontinue them if whether you're doing stretches or the child just inherently doesn't have tight range, then I may discontinue them and let the guilt sort of fall away. People have a lot on their plates, and I don't want to add to your plate, especially adding to a plate when it's not of real benefit. I'm happy to remove that.
I was just going to add some comment to that. And it goes with any kind of medication. I would much rather have a parent come to me and say, hey, look, this isn't working, as compared to just kind of letting it slide and then having to have that whole conversation. Like, as a lung doctor, I take care of a lot of asthmatics. Like, I'd rather them say, I'm not taking my inhaler every day, as compared to saying, oh, I'm taking it, but then I can see like they have lots of symptoms where I'm just going to increase the dose as compared to trying to figure out how do I get them to take their inhaler, how do I get them to wear the AFO better. Like we can help much easier if we know like that, you know, and I don't think, I try to be as least judgmental as possible. Like I always say like, I'm not going to get upset at you if you tell me you're not using this. I need to, if you're not using it, we need to figure out like how we can make it better if they need it. So it's just, it's so much easier if you feel comfortable having that open conversation with your caregivers in clinic moving forward, because there's going to be a lot of difficult conversations at some point that with that kind of basis, I think it's easier to talk about.
We had a podcast episode here maybe a month or two back, and I don't even remember the topic of the podcast, but this exact thing came up. And they were talking about like, oh yeah, what do you say? It was a bunch of moms. What do you say when the doctor asks if you wear your AFOs at night? And they all three agreed that they lied. Mm-hmm. Yeah, we just say we wear them and then move on.
Actually, I mean, there's data out there that people do about 40% of what we prescribe. They take about 40% of their medicines. They do about, and this study I think has been done over and over again, different age groups, you know. So it's so much easier for us as practitioners to know, like, I'm okay, like, I get it. They have issues, their feet sweat, like, you know, I would rather someone say to me, no, we haven't worn it for 3 months. And then, like you said, you can do a better exam and try to figure out, like, are there other ways of doing it? Exactly. Is there another medicine? I have the same issue with the older kids who I ask them every time. So, when was the last time you did your cough assist? You know, when was the last time you did your BiPAP? Now, BiPAP machines have a little card in it that I can download. Or I can ask the home care company to send me a download. You know, they may tell me that they wear it every night, and then they know 3 weeks later I'm going to get this download that says, they wore it 4 nights out of the last month. So then we have a different conversation.
So it's okay to be honest with your provider.
Absolutely.
They're not going to judge you.
Yes.
They're going to problem solve with you.
Yeah.
For sure.
All right. We are at 2 minutes to the hour. Does anybody want to have honors of last question? Okay. We're going to take one last question, and then we will cruise on into a break.
It's just a really quick question on the neuropsych testing. My son is nonverbal, doesn't follow most commands, although not many kids do. Is that something that he's still able to do?
Yes. Yep. So there's different types of tests. Some require verbal sort of skills, and others do not. So some of the puzzle tests. Some of them are observational, that the neuropsychologist can just do some observations, and I think still get some value out of it. You may get some different data than what you might obtain if it was a traditional neuropsych testing, but I think still a value. And so you may want to, talk to your care team. There are different, within my clinic setting, we have one person in particular. We have 3 neuropsychologists that take care of kids with Duchenne. And one of them in particular is the person that we send the kids who are less verbal, or we have questions about autism spectrum. And Dr. Petranovich is the one that we would send because that's her skill set and area of interest. So you might want to talk to your team about who that perfect person would be.
Okay, right on time. Look at us. Okay, well, I want to say thank you to Eric and Richard and Sue and Grace for all of your insight and expertise. And thank you to you guys for all of your really, really great questions. I know that I learned a lot, and hopefully you learned a lot from some of the other folks' questions and their answers. So we'll go ahead and wrap it up. We are on a break until 3:15, and then choose your own adventure. I think there's lots of different things going on. So thank you so much, everybody.